health, strengthening disability inclusion, mainstream services. UNICEF attaches a high priority to mainstreaming disability inclusion within health services, including across sectors as well. So it's a multi-sector perspective that we would like to take, and we do take. Universal health coverage and SDGs are unattainable if people with disabilities continue to be excluded from receiving the health services they need. Unfortunately, as we all know too well, the COVID-19 pandemic has spotlighted and worsened in many ways the barriers to health experienced by people with disabilities. So these people require both specialized medical care related to specific impairments, but also access to all routine general health programs and services. In other words, they have the same healthcare needs as everyone else, right? The rest of us. We are really pleased to have this time to focus on making routine general healthcare more inclusive of people with disabilities. And we want to give a sincere vote of appreciation and to thank UNICEF's co-sponsors for the side event. I think that they've already been mentioned, but I'd like to mention it again, and especially to the Ministries of Health from Bangladesh, Philippines, and Uganda. So welcome. Thank you for being with us. And also the colleagues from Humanity and Inclusion, Missing Billion Initiative, the UK Foreign Commonwealth Development Office, FCDO, and WHO. We're also very lucky to have other speakers with us sharing their experiences and insight. We especially look forward to hearing from our dear advocates, Jasmine, Florence, Anita, and Nicholas. So welcome. So the three things that Lue suggested should be spotlighted from UNICEF's side. One, UNICEF's health programs. We are determined to drive improvements in accessibility, acceptability, quality, and inclusiveness of UNICEF's health programs. Internal practical guidance will be provided to all UNICEF staff and our partners. We're building our own capacity on inclusive health. We will strengthen internal systems to secure positive change. We want UNICEF to be outstanding in this field. The second main point, we want to support governments on systemic change. At the summit, we have committed to supporting 15 countries to strengthen disability inclusive primary healthcare and health systems by 2026. Our work here will include support around the UN Convention of Rights of Persons with Disabilities and compliant health budgeting, inclusive health strategies, as well as strengthening health policies. We will focus on disability inclusion across sectors, such as WASH, sexual reproductive health rights, and HIV programs. We want to help partner governments be responsive to the intersectional vulnerabilities of mothers, adolescents, and children with disabilities. We will also help strengthen early identification systems for children and youth with disabilities across multiple sectors. And the final point is we need to raise the agenda globally. And so we are also determined to see disability inclusion in health receive a greater profile and commitment at national and global levels. This summit and the side event is a valuable stepping stone toward that. And we look forward to building on this today, including through the Global Action on Disability and in partnership with the organizations here today. On that note, and in behalf of Lue, I would like to sincerely thank all who have worked on preparing the side event and look forward to the proceedings of today. Thank you, and back to you, Anna.
Thank you, Rory. It's wonderful to hear about these commitments and plans on behalf of UNICEF. I turn next now to Alessandra Aresu. She is the Director of the Global Health Division at Humanity and Inclusion.
Thank you, Hannah. And good morning, good afternoon, and good evening, everybody. At Humanity and Inclusion, I lead a team of 8 staff members working on disability inclusion in the health sector that support projects around the world on inclusive sexual and reproductive health and rights, maternal, newborn, and child health, non-communicable diseases, emerging infectious diseases, and mental health and psychosocial support. In addition, we have a full team also dedicated to rehabilitation. And at HI, we have identified a set of keywords to summarize our contribution to making the global health agenda more inclusive in the future. The first 2 keywords are partnership and influencing. We believe that influencing global health stakeholders and partnering with them and with organizations of persons with disabilities is key to make the global health agenda more inclusive of persons with disabilities. And that thanks to our expertise and long-term experience, we can play a key role in doing so, as our work and strengths are complementary to those of our partners, and joining forces and resources is key for us. The second set of keywords are inclusive mental health and psychosocial support and sharing lessons learned on inclusive sexual and reproductive health and rights. Through our mental health and psychosocial support work, we have served people in both development and crisis and emergency settings to promote their well-being as well as their rights. With our experience and expertise, we believe we can do much more to offer inclusive information and services in this sector, and to ensure that the barriers that still prevent many people with disabilities to access mental health and psychosocial support services are addressed and removed. And when it comes to disability inclusion in sexual and reproductive health and rights, we have been working for several years already as members of consortia like the Women Integrated Sexual Health program led by the International Planned Parenthood Federation and funded by the UK government. Our next step is to share about this experience and learning by developing innovative guidelines and training to support the work of sexual and reproductive health and rights and disability actors, including on the important topic of informed consent that is key to promote the sexual and reproductive health and rights for all. And the third set of keywords is advocating through networks, joining forces with other allies and partners to continue advocating via networks and platforms for the implementation of Article 25 of the CRPD and the World Health Assembly resolution on the highest attainable standard of health for persons with disabilities is essential for us. And of course, continued and renewed advocacy with key partners rather than as a single organization is essential to influence policies and strategic planning. And we cannot forget, of course, resource mobilization. Our experience is extensive within networks like IDDC, the International Disability and Development Consortium, and I believe we can do much more as a group than as singles. And thank you. Back to you, Hannah.
Thank you, Alessandra, and thank you to HI for being such champions in this area for so long. So now we have Darren Welch, who's the Director of Global Health in COVID-19 Directorate from the UK Foreign, Commonwealth and Development Office.
Thank you, Hannah. It's an enormous pleasure to be co-sponsoring this event. Thank you so much for inviting me along. And we're really passionate about this the agenda of this event at the Foreign, Commonwealth and Development Office. And we believe strongly in the importance of mainstreaming disability inclusion right across our policy work, including our broader global health portfolio, which I am responsible for. And you set us the challenge of three things that we want to be taking forward. Let me set them out from our point of view. First of all, we want to ensure that throughout our programming work, we are really achieving meaningful participation of people with disabilities in that work and in our planning through their genuine and meaningful involvement and consultation, especially at the country level. So we're hearing from the beneficiaries we want to work with. To give an example here, we are an active member of the Partnership for Maternal, Newborn and Child Health, with more than 1,000 partners around the world, stepping up its voice on profiling the needs and rights of people with disabilities across its global advocacy efforts. And we will be working with PMNCH, as the Commission on the Status of Women, to advance this agenda through the integration of women and girls with disabilities into mainstream gender advocacy conversations that we will be having with senior partners. So that's the first thing. The second is we want to be doing much more to collect and analyse data disaggregated by disability measures to help us build the evidence base we need so we can move from data to knowledge to policy. That will be a really important part of how we're going to take forward the agenda. And thirdly, we're seeking to influence our partners and bilateral relationships around the world to ensure we can help fulfill the right of everyone, including people with disabilities, to good health and well-being, leaving no one behind, in that language of the SDGs. And Alessandra just mentioned our Women's Integrated Sexual Health flagship program that's currently working in 12 countries in Africa. And working with partners, we've undertaken an assessment with organisations of persons with disabilities to address barriers which prevent people with disabilities from realising their full sexual and reproductive health and rights. I'm really pleased to say that that programme will be extended to continue its work in 2022 to 2023 and will restart in 5 more countries. Those are 3 really practical things we are going to be taking forward as the UK government. But we will also be mainstreaming disability inclusion through our strategies and policies. And I'm pleased that yesterday, one of our ministers, our Minister for Disability Inclusion, Minister Ford, announced the launch of an updated disability inclusion and rights strategy for our organisation, setting out our ambitions to 2030. What we will do externally, but also how we will improve our own internal performance and the way in which we support and empower our staff with disabilities. And last year, we also published a health system strengthening position paper and a paper on our strategy to end preventable deaths globally. And both of those mainstream disability inclusion across those really important agendas. So I hope I've been able to set out how the UK remains committed to playing a strong leadership role on this important agenda, working together with the co-sponsors and other partners globally. Thank you so much. I wish you a really successful rest of the event.
Thank you, Darren, and thank you to FCDO for being so important in setting this agenda. So last but certainly not least, I turn to Professor Alaka Sieza, who's been driving the agendas on vision, hearing, rehabilitation and disability at the WHO.
Thank you, Hannah, and what a great pleasure for me to be here today and also to see health so prominent in the agenda of the Global Disability Summit. And in terms of your question, Hannah, first of all, I would say that WHO has the capacity to bring the right people on the table to bring or to make disability inclusion a political priority in health. An example of that is the editorial that was published today at the British Medical Journal, one of the most well-recognized journals in the health sector, with Dr. Tedros, with 2 heads of states, Norway and Ghana, and the International Disability Alliance. So that is, of course, due to the convening power that WHO has in the health sector and also beyond. But beyond this convening power that WHO has, that gives the capacity to bring the right people on the table, I would like to mention 3 of the core functions that WHO has and that are fundamental for disability inclusion in the health sector. The first one is the development of norms and standards. And all of you know well the 2011 World Report on Disability, what is considered also a document that is a standard or a normative document published by the World Bank and WHO in cooperation. Now we are proceeding, and we will launch at the end of the year a global report on the highest attainable standard of health for persons with disabilities, focusing indeed on the health sector and how the health sector needs to be disability inclusion to achieve the objectives of the health sector, as you were saying, Hannah, at the beginning. This is a normative document because it has recommendations, and what we have also, we are developing at the same time, is a guide for action to implement those recommendations. So it is really emphasizing now again the normative in terms of how WHO contributes creating this kind of norms and standards. But another function of WHO is country support. And what that really means for WHO is really collaborating with ministries of health. And in this case, is really collaborating with many ministries of health to make the health sector inclusive. Can you hear me? Because I see that the sign language has stopped, and I don't know if it is because you don't hear me or.
I can hear you, Alakos.
Okay, good. Should I proceed without sign language? Yeah?
Yeah.
Okay, good, perfect. Thank you. And so it is really collaborating with ministries of health. WHO is the Secretariat of Ministries of Health, and therefore the implementation of these norms and standards is done upon request and from ministries of health and with ministries of health. And last, even if I make a fourth point, Hannah, is really the data and monitoring. And it is about data disaggregation by disability, but also moving forward will be more and more important to include indicators into health information systems. So I stop there, and thank you all. A pleasure to be a co-sponsor of this event.
And thank you, Alakos, for helping to lead this agenda. So now I move to the next part of the side event, where we will focus on lived experience and individual expectations for the health sector from speakers from 3 corners of the world. So first, let me introduce Jasmine Sharif from Pakistan. Jasmine, are you ready? So yes. Jasmine, before I ask you a question, please can you describe yourself to our participants?
Sure. My name is Jasmine Sharif. I am a young woman with long black hair, and I am wearing a green color shirt. I was diagnosed with Soto syndrome when I was 10 years old and have an intellectual disability.
It's lovely to meet you. So Jasmine, tell me about what you think are top actions that health sectors can take to better serve people with intellectual disabilities.
A very important one has to do with training. Doctors and other people involved in health really need to learn how to care for people with IT. Not everyone learns this in school. Not everyone has met people like me. Doctors may have ideas that aren't true about people with IT. They need to know that we deserve respect, kindness, be more patient and listen to us, just like they do to their other patients. The health sector also needs to give people with IT information and support. I feel we don't talk a lot about this. In my own life, I know how to identify if I am feeling sick. When I feel sick, I tell my mom to make an appointment for me. I have gone to the same family doctor since I was a child. My experience is usually good, but I have never gone by myself as I would be shy or scared. So I always go with my mom or dad. I have the best experience when I go with my mom. I am very close to my mom. She is everything to me. When we go to the doctor, I talk to a doctor myself, and my mom adds on if she needs to. When the COVID-19 pandemic started, only the patient could see the doctor. They could not have a support person with them. But when seeing a doctor, it is very important for people with IT to be allowed to have a chosen support person, even in the pandemic situation. Having my mom come with me to the doctor is one way that I feel supported. There are other ways that given us information to keep ourselves healthy. I get a lot of health information from Special Olympics. They provide information with lots of pictures and things that we can hold in our hands. We also have talks where someone explains the information to us and we can ask questions. I have learned so much, and I teach my fellow athletes with intellectual disabilities about how to be healthy and how to speak to the doctors. Thank you.
Thank you so much, Jasmine, for that excellent presentation and for the very great tips that you have for making health systems more disability inclusive. So next, I'm going to turn to Florence Ndagiri from Uganda. Florence, I believe that you want to share some of your experiences of the health system with the audience today.
Yes, thank you very much. My name is Florence Ndagiri, as she has introduced me. I was born visually impaired and I've lived the rest of my life with blindness. I have experience to share on aspects of inclusive healthcare, products, information, and the infrastructure. As a mother with a disability, I have on several occasions required access to healthcare services from health workers here in Uganda and abroad. In my experience, I have found out that in the absence of accessible health facilities, information and assistive devices, the attitudes of health workers towards persons with disabilities is seeking for health services is very critical in the promotion of inclusive universal health coverage for all. When I was expecting my first child in 2010, I needed a lot of medical attention since I was anemic. I had to attend antenatal care on a monthly basis to enable the medical personnel to monitor my health condition. And every time I went there, I didn't have a personal assistant. I am happy to say that in spite of the inaccessible infrastructure, information and products, the health workers who attended to me had a positive attitude towards me as a person with a disability. The nurse escorted me to the laboratory to take the medical test. She made sure that she read for me the results since I couldn't read, helped me to access the examination table to check on my pregnancy, taught me how to take care of the child when he's born, prepared me for labor by explaining to me all the signs, and the same treatment continued until I gave birth to my baby. So a call to action: disability does not discriminate, but services and people do. We need the support of health workers in order to access inclusive and universal health services. You need to have accessible hearts in order to promote inclusive health care. Providing health services to persons with disabilities does not require a big budget. It requires innovation, creativity, and cooperation between the health worker and the person with a disability seeking for services. Consult us to discuss our individual needs and provide the necessary adjustments to meet those needs. If I'm a wheelchair user and the maternity ward is on the upper floor, come and attend to me on the ground floor. If I am blind and I cannot access prescriptions in Braille, please read for me the prescription. If I am deaf and cannot hear you, ensure that you write or provide sign language interpretation. If I have psychosocial or intellectual disability, provide information in simple, easy to read and plain language. Together, we can positively change the global health agenda by strengthening disability inclusion across health programs for God and my country.
Thank you, Florence, and thank you for those very practical tips and suggestions about what healthcare workers can do. So finally, in this section, I'm going to turn to Dr. Anita Brito and Nicholas Brito, a mother and son from Brazil. So what would you like to share with the audience today?
Hello, everyone. I'm Dr. Anita Brito. This is my son, and I have brown eyes and brown hair, and I am wearing a black shirt. Behind me, there are books which I really have read, okay? So I'm going to share some experience of us. Well, growing up, I was an incredibly awkward and intelligent child, always studying and reading all of the books that I could get my hands on. My father is not an especially expressive person and has never made eye contact. My brother was blessed with an absurd amount of intelligence, yet he had immense difficulty making friends as he got older. And crippled by loneliness, he attempted to take his own life on 2 separate occasions. Fortunately for him and us, he did not succeed. When I became a mother, I was elated, but my happiness was coupled with the burden of worry, as early on, my son, Nicholas, showed many signs of autism and disabilities in general. He was completely content if left alone in his cradle, never cried, never seemed to get hungry, never used his voice to communicate, among other signs and things. I knew to my core that something was amiss. I asked the doctors if it was possible that he could be autistic, and they all responded the same. Oh, he can't be autistic. Look at how handsome he is. Although I was happy to hear how handsome everyone thought my baby was, perhaps he was the cutest baby ever, he was still, and he still is autistic, and he is handsome. He's both things. And Nicholas was diagnosed with autism when he was 5 years of age. My diagnosis, as well as my brothers and fathers, came much later in life, as we were officially diagnosed in 2014. I can barely put into words what an early diagnosis would have meant for all of us. Today, there continues to be a complete lack of resources to assist those who have autism here in Brazil, largely due to a healthcare system that supports policies grounded on pseudoscience with no evidence whatsoever. We continue to have countless severe autistic people in chains or caged inside their homes with no therapeutic support. Regardless of the level of autism, your age, your educational degree, autistic people are neither seen nor respected.
Hi, I'm Nicholas. I'm autistic. I have brown hair and brown eyes, and I'm wearing a black t-shirt. Well, if I'm here communicating and using my voice, I have to thank my mom, who's never given up on me and helped me find my voice. Now I can tell the world through lectures and my books that I'm happy. Where I am today is due to my mom's efforts and not because of our healthcare system. But what about those who don't have a mom like mine? My final message is, not all human beings are autistic, but every autistic is a human being. So we deserve to be treated with respect. Thank you very much.
Thank you very much.
Thank you so much for those testimonies and for those suggestions. So let us now start to think about concrete actions in the health system to make them more inclusive of persons with disabilities. I will present a framework to help structure our thinking a little bit, and it's now shown here on the screen. The diagram on the screen shows 9 different components that are needed to make a health system inclusive. Often our first thoughts will go to what happens in the clinic and what is needed there to be inclusive. In the figure, this relates to the 3 supply side components in the middle of the diagram. Issues that arise here include, first, the lack of trained and available human resources, second, inaccessible health facilities, and third, the lack of availability of rehabilitation services and assistive technology. However, 2 demand side issues also often arise. First, the lack of autonomy and awareness of persons with disabilities about their needs for health systems and how to fill them. And second, the lack of affordability. However, these observable service level failures that are shown in the center of the diagram arise from 4 systemic issues underlying these issues, and these are shown to the left in the figure. These 4 elements are categorized here as a lack of governance, leadership, financing, or data and evidence. These failures together lead to poorer health coverage for people with disabilities and ultimately poorer health outcomes, shown here on the right-hand side of the diagram. We know about these problems, but we can also flip them to turn them into entry points for solutions or must-haves that health systems should have to be inclusive of persons with disabilities. This can include good governance, so policies and laws in place to protect the right to healthcare of persons with disabilities, clear leadership of this issue in ministries of health, health financing mechanisms to support disability inclusion, and good data and evidence to show us where the need is and what interventions work best. At the service level, we must support persons with disabilities to make their own decisions about healthcare and to be able to afford this care. There must be a well-trained health workforce who is knowledgeable about disability, as our speakers have just highlighted. There must be accessible services and the availability of rehabilitation and assistive technology. With these fundamentals in place, we will have better coverage of health services for persons with disabilities and therefore better health outcomes. We will now learn about promising country-level activities to strengthen disability inclusion in mainstream health services. We have chosen these examples to highlight different components of the disability inclusive health system framework that I have just presented. These are real-life examples to provide inspiration and to show us that achieving inclusion is possible. So first, let me introduce Dr. Satendra Singh from the University College of Medical Sciences in India, who will talk about the supply side of delivery, talking specifically about inclusive healthcare worker training.
Thank you so much, Hannah. I am Satendra Singh, Professor at the College of Medical Sciences. Now, we all know that there are health disparities when we talk about the missing billion, the 15% of world's population. But when we look at the people with disabilities, they are part of two interdependent systems. The first system is the education system, which is health professional or graduate health professionals. And the second system is the health system, which provide services to patients with disabilities. Now, if we look at the broader situations, in the most recent survey in February 2021, around 82% of the US physicians still believe that the quality of life of people with disabilities is worse than non-disabled people. Only 41% are certain that they can provide the same level of care than to the non-disabled people. Likewise, 87% of nursing students link negative traits with physical disability. Down under, in the University of Sydney, they have identified the level of integration of disability rights within the allied health professionals continuum, and there is a greater variability. In short, there is a medicalization because of the still prevalent medical model of disability. How can we counter this? I will provide you very short two examples. The maximum number of medical colleges across the globe are in India, 619 to be precise. And for the very first time in 22 years, the National Medical Commission in India changed the medical curriculum to competency-based curriculum to conform to the global demand or global norms. However, it still relied heavily on the medical model of disability, as the key words from the CRPD like dignity, accessibility, non-discrimination were absent from the curriculum. I led a project to prepare disability competencies for health professionals by involving three key stakeholders: disability rights activists, doctors with disabilities, and health professional educators, which led to the formation of 27 competency for a health professional graduate, which they must know about disability. India recently has ratified its new disability. India has ratified the CRPD. Therefore, in 2016, we have our new law, Rights of Persons with Disabilities Act. And the section 39(2)(f) very categorically states to ensure that the rights of people with disabilities are included in the curriculum in universities, colleges, and schools. Using this clause, this legal provision, I filed petition at the Chief Commissioner for the Persons with Disabilities, whereby the Ministry of Health and later on the National Medical Commission, they were forced to include disability competencies as a mandatory part in the new medical curriculum. In other countries, the disability competencies are still either optional as part of elective or non-existent. Recently, the National Council on Disability in the US has acknowledged the lack of disability training and has requested return to the ACGME to incorporate disability competencies in the health professionals training. The second part of this is, the education system, because ultimately there will be health professionals. But here we need to see that what are the barriers at the entry level, at the supply levels. The reason why we don't see health professionals or students with disabilities is because of the discriminatory guidelines, admission guidelines at the very beginning, which prevent their admission in medical and nursing curriculum and physiotherapy curriculum. That's why we need to change them. The second global practice I would like to highlight is the International Council for Disability Inclusion in Medical Education. This council is producing a global guidance on shared principles about supporting qualified learners, disabled individuals, medical professions. The report will be out next month. 4 countries, India, China, Brazil, and US, have more than 150 medical schools, and even 36 countries globally have no medical schools at all. Therefore, the Council in the second year will be developing a template of reasonable accommodations to support learners with disabilities where there are no existence internationally. So to conclude, my 2 suggestions at the entry level would be, at the level of the education system, would be to empower learners with disabilities into health professions education and acknowledge their lived experience as expertise to tackle health disparities. At the level of health system, we need to integrate disability rights as disability competencies mandatorily into the curriculum and not as optional part of the curriculum. Thank you so much.
Thank you, Dr. Satendra, and congratulations on all your efforts. I just would like to, we're running a little bit behind time, so I'm going to ask the remainder of the panelists to make sure they stick to time so that we have time for a discussion. So next, I'm going to introduce Tala Ismail Al-Ramahi from the Crown Prince Court, UAE, who will focus on data and evidence, talking specifically about Abu Dhabi's COVID-19 home testing and vaccination. Thank you very much.
Thank you, Hannah, and thank you everyone for being here today. As Hannah mentioned, my name is Tala Al-Ramahi. I am an Associate Director at the Office of Strategic Affairs at the Crown Prince Court. A big part of what we do is advise on public policy related to social and economic issues pertaining to the UAE. And I want to talk to you today about the efforts that the UAE had spearheaded during the pandemic to ensure equal access to both testing and vaccines for people with disabilities. Just in terms of providing the bigger picture on vaccination rates within the country, the UAE continues to lead globally on the percentage of people who are fully vaccinated. So currently we have, I think, according to the latest data, around 95% of the population is fully vaccinated. There has been a big push from the government to ensure that everyone has access to vaccines. Earlier on, once the vaccines were introduced, giving people the choice for which vaccine they would like to take. In terms of how the UAE has enabled or even prioritized access for vaccines for people with disabilities, the UAE launched what is called the National Home Testing Program for people of determination. So for people who are on here today, the UAE a couple of years ago changed the terminology that we refer to people with disability to people of determination, hence the name National Home Testing Program for People of Determination. So this is a home vaccination drive for people with disabilities, as well as elderly members of the community. They are able to get the vaccine at their home and provided easy access through either requesting the vaccine over the phone or through a digital platform. The vaccine would be delivered and administered through a health provider or health practitioner. And this was done throughout the pandemic and continues to operate until today. Another thing that I would mention as well, last year, so in February of last year, when we saw a spike in the infections and also some challenges with getting enough vaccines for the population, the UAE prioritized the first doses of the vaccines and limited them for members of the elderly community, as well as people with disabilities and chronic illnesses. So for a period of 6 weeks, the priority was given to people with disabilities, people with chronic illnesses, and the elderly. Another thing I would mention as well is the cost of the PCR test. So in many countries, the cost of a PCR test continues to be quite prohibitive for a lot of people to access. In the Emirates of Abu Dhabi particularly, the cost of a PCR test was capped at around 50 dirhams, which is the equivalent of $14 US. And that was aimed at ensuring that, you know, almost everyone can afford the test if they needed it. For low-income groups, the test was provided for free. So there were free walk-through testing sites scattered around the Emirates or the city for people to get a PCR test if they needed that. They did not have to prove whether they could or could not afford the PCR test. So any member of the community can go and get access to a PCR test. I also just really want to touch quickly on another aspect of health service delivery for people with intellectual disabilities. And we heard earlier from Jasmine, who represented the Special Olympic community. So I serve on the board of Special Olympics UAE, and just recently the local program here in the UAE was given the Golizano Health Leadership Award. This was primarily due to the efforts that they spearheaded during the pandemic to provide inclusive healthcare services for people with intellectual disabilities, more specifically, and to ensure that these health disparities during the pandemic were addressed through the programs delivered through Special Olympics UAE. I would mention just more specifically on that program, healthcare workers, hundreds of healthcare workers were trained to be able to properly assess and diagnose people with intellectual disabilities and to provide them with the access and care that they needed during this time. What was also quite interesting, I thought, you know, the pandemic has affected the mental health of everyone really through this time. And what Special Olympics UAE was able to do was provide a mental health program, mental health support program for their athletes virtually. So just an example, they set up a cooking club as well as a gardening program where they would deliver these the ingredients to the Special Olympic athletes or people with intellectual disabilities, and then provide them virtually with a program to help nourish and support their mental well-being during the pandemic. So this is just some of the examples of how the UAE has been trying to ensure and prioritize access for people with disabilities during this difficult time.
Thank you very much. Thank you very much, Hala, and congratulations on UAE's vaccination program. So now we have Dr. Noor Nahar Begum from the Ministry of Health and Family Welfare in Bangladesh. She will focus on governance, legislation and policy, describing efforts to ensure disability inclusive family planning services.
Thank you, Hannah. Assalamu alaikum, respective panelists, honorable participants, ladies and gentlemen, welcome to you all. I am Dr. Noor Nahar Begum, Line Director, Clinical Contraception Services Delivery Program, Director General of Family Planning of Bangladesh. I want to share Bangladesh government's initiative towards disability inclusive SRAs. Bangladesh government signed the UN CRPD in 2007. Disability inclusive SRAs is one of the focal agenda of the government of Bangladesh to achieve Sustainable Development Goal. Bangladesh government issued Rights and Protection of Persons with Disability Act on 2013 to ensure different rights of persons with disabilities. To carry out health and nutrition program, Bangladesh government developed national strategy known as Fourth Health Population Nutrition Sector Program 2017 to 2022. To implement this sector program, there are several operation plans. As a part of ensuring disability inclusive family planning services, clinical contraception services delivery program, Unit of Director General of Family Planning revised the operational plan and included the disability issue in the operational plan for the first time in Bangladesh. Handicap International provided some technical support to include these disability inclusive SRAs in the operational plan. We are proactive to take different action regarding inclusive family planning and SRAs in Director General of Family Planning activities, such as with technical and financial support of Handicap International, a national context analysis on the rights of persons with disabilities regarding SRAs was conducted in February 2020. The recommendation of context analysis was shared with relevant stakeholders of Director General of Family Planning and Director General of Health Service for further action. A technical working committee on disability inclusive family planning HRAs has been formed in March 2020. In the committee, we included 2 representatives from OPD, Organization of Persons with Disabilities, for addressing their needs and difficulties of persons with disabilities differ directly from them. We included inclusive SRAs in the National Family Planning Manual to ensure the capacity building of family planning service provider on inclusive SRAs issues. We prepare SOP on disability inclusive SRAs, which was developed. The process of development through a constant consultation with the which is funded by UNFPA and Handicap International is providing technical support. We prepare some special BCC materials for adolescent person with disabilities about menstrual hygiene also. Currently, we are developing an action plan in the line of standard operation plan to implementing disability inclusive SRAs. And lastly, we try to advocacy on the to include disability issue in the operational plan of maternal and child reproductive adolescent health program operation plan also. I myself and our Honorable Director General of Family Planning is positive with the objective to include family planning SRA services to persons with disabilities. We will try to accommodate actions to incorporate family planning SRA services for all to comprise the slogan, "No one leaving behind." Thank you so much. Thank you, Hannah.
Thank you, Dr. Narun, and congratulations on this multifaceted effort. I hope we're going to have a little bit of time for discussion in a minute. So do remember to put in your questions in the Q&A section, but also to the remaining speakers to keep to time where possible. So next I introduce Dr. Beverly Lorraine Ho from the Department of Health in the Philippines, and she will consider financing specifically efforts towards supporting mainstreaming of disability inclusion. Thank you, Dr. Ho.
Thank you very much, Hannah, and good morning and good afternoon to everyone who's joining us. And it's early morning here in the Philippines, and allow me to acknowledge my colleagues from the state insurer PhilHealth who are also here with us today, Dr. Melanie Santillan and Ms. Merla Rose David. Families or households caring for children with disabilities face the triple financial burden. These are additional costs of accessing general non-disability specific services, cost of accessing disability-specific goods and services, and of course, limited earning opportunities. Today, I will talk about number 2, or cost of accessing disability-specific health goods and services, and humbly share with you our experience in health financing for children with disabilities in the Philippines. Like many countries, the Philippines is also embarking on a series of reforms towards progressive realization of universal health coverage, wherein it has already been set that financing is the main responsibility of the state health insurer, particularly for individual-based health services. Healthcare provision is expected to be provided by both public and private sector, particularly with a huge private sector market in the country. And finally, the Department of Health is the regulator and standard setting agency. In 2015, PhilHealth began financing packages for adult persons with disabilities. This means making available fully financed benefit packages covering assistive devices such as upper and lower limb prosthesis, lower limb orthosis, and spinal orthosis with rehabilitation sessions in 4 government facilities and 3 private facilities. This was the springboard for the country to move towards supporting children with disabilities. With the support of UNICEF Philippines and several other partners, our PhilHealth led the development of benefit packages covering 1, developmental disabilities, 2, mobility impairment, 3, visual disabilities, and 4, hearing impairments for children less than 18 years old. Admittedly, the limitation is these can only be accessed in fewer health facilities now as we're starting up, but efforts are underway to contract more facilities. These packages include various interventions ranging from assessment by medical specialists, assessment by allied health specialists, rehabilitation therapy, assistive devices like prosthesis, orthesis, spinal bracing, seating devices, wheelchair, hearing aid, optical aid, electric aid, and white cane. By going through the financing route, the country is able to immediately address the needs of children with disabilities in areas where providers are available. However, similar to past experiences, we also expect PhilHealth's financing to serve as a market signal to trigger supply-side investments from the private sector as well as from local government units, especially in our case where healthcare system is fully devolved. Also, with the stewardship of the Ministries of Health and Education, this PhilHealth benefit package also has historically served to trigger reforms in health professional education to respond to the health human resource gap. So I end there, so we'll have more time for Q&A, hopefully. Back to you, Hannah.
Thank you, Dr. Hearn. I can see that it's actually the middle of the night for you, so thank you for staying up so late. Next, we turn to Stanley Bubikire from the Ministry of Health in Uganda, who will focus on governance, specifically Uganda's policy on disability inclusive health and spotlighting the work with UNICEF on early identification.
Thank you very much.
Hello, Stanley, are you there?
Can you hear me now?
We can hear you. Thank you.
Thank you very much. Like you have said, Dr. Stanley Rich is my name, and I'm the Assistant Commissioner of Health Services in charge of disability and rehabilitation. I want to point out that in Uganda, we do an integrated approach to health services, and some of the elements in the health systems that we are emphasizing to be strengthened in regard to disability inclusion is the area of human resources, where rehabilitative health care workers are a target for our training. We are working on leadership development, coordination, and joint planning. And financing is a key issue, both from government and the private and NGOs. Advocacy is one of our areas. It has worked where we have used it, especially in eye care, and the supply chain for essential supplies. We are starting an assistive technology advisory committee for the purpose of assistive devices. And we have actually a robust health management information system for the last 2 years. And we are also now emphasizing evidence generation through research. I want to say that we are guided by Universal Health Standard Sustainable Development Goals. We are also guided by the National Development Plan 3 in the country, which emphasizes equitable service provision, all categories of people, and the National Health Policy for the Ministry of Health that entails essential services and our minimum package, rehabilitative healthcare inclusive. And we do that in an integrated manner, emphasizing primary health care. Allow me just briefly to mention some of the specific healthcare program achievements that entail disability inclusion. One of them is that we have established a number of regional orthopedic workshops in our regional hospitals that fabricate assistive devices. We have a well-equipped optical workshop that actually works on spectacles for refractive errors. I have already talked about several rehabilitative healthcare workers, although they are not enough. I also want to say that we actually developed the national wheelchair standards that are guiding quality supply of wheelchairs. And we have established quite a number of health training institutions. And this includes physiotherapy, occupational therapy schools, speech and language, psychiatric, school for psychiatric clinical officers, and more recently, the School for Optometry, Bachelor of Science. And the Mental Health Act was passed in 2018, which provides legal framework for mental health services. Our Uganda expanded program on immunization included rubella vaccine, among others. And this one, you know, has a good impact of counteracting the rubella disabilities from the heart, hearing, and visual disability that we used to see quite a lot. Vitamin A supplement is also very helpful in the area of preventing blindness, and polio vaccination still continues. We have a department for non-communicable diseases, as we are aware that this one actually also leads to a lot of disabilities. Some of our programs like tuberculosis and leprosy and neglected tropical disease programs look for and they manage disability arising from leprosy and diseases like trachoma and elephantiasis. And then we also have corrective surgeries in the area of hearing impairment, orthopedics, and ophthalmology. And I also want to say that we have established special hospitals in collaboration with other private partners such as KOSU, CHUA, Benedictine Eye Hospital, Mengo, Roharo Eye Tertiary Institutions, and more are being put up. I also want to share with you that in partnership with UNICEF, we are implementing a project on intervention for disability in early childhood. This helps us to identify the children with the disabilities very early and then provide appropriate interventions and make referrals as and when necessary. We are currently doing it in 6 pilot districts. And with the experiences that we hope to gain, we shall scale up to other countries together with the collaboration in UNICEF. We have had as a ministry to have the opportunity to chair the Interministerial Technical Committee that includes the academia, the DPOs, NGOs, and other agencies. I've already said that we are developing the National Advisory Committee on Assistive Technology, which will guide the MOH and stakeholders on to handle this area. And some of the areas which we are also looking at is making sure that we influence the essential medicines and other supplies list to cater for different types of disabilities. One of our recent successes was to have skin creams for albinos, and we shall continue doing that. We have also had a collaboration with Sense International.
Sorry, Mr. Sandra, thank you so much, but is it possible to start to wrap up?
Okay, thank you. Allow me now to talk about, although we are having successes in those areas, we have some challenges. The challenges include inadequate human resource, they are still not enough, gross underfunding, referral mechanisms still need improvement. And the data, although it is robust, it is only 2 years ago, so we don't have very old data that helps us from the previous years. But we hope that with time, this robust HMIS we have established will help us. Thank you.
Thank you so much. And so finally, I'm going to turn to Professor Linamara Rizzo Batistella from the University of Sao Paulo, Brazil, who will describe how leadership and political prioritization was achieved for these issues in Brazil. And we're really almost out of time, so I'm going to really beg her to keep to the few minutes we have. Thank you. Professor Linamara, you're on mute.
Thank you for this incredible invitation. It's a fantastic meeting. And I try to talk about our country, but more about our state, São Paulo state. Assistance to people with disability in Brazil date of the time of the empire, offered mainly by philanthropic institutions. However, from 1981, the International Year of People with Disability, the movement of the rights of people with disability begins to have an active voice in policies. The movement assumes a preeminent role due to the rapid industrialization that Brazil experienced, and the Brazilian government organized a network, a very strong network of professional rehabilitation centers. These centers combine the clinical rehabilitation care, provision of assistive technology, and return to work training. This comprehensive model of rehabilitation focused on returning to productive activity was very well successful. Professional rehabilitation was responsible by inspiring the improvement of the rehabilitation medicine to others functional limitations resulting from different causes, for instance, from infectious diseases and chronic health conditions. But the assistance was still outside the health system, and it was a problem. 1992 was the beginning of a new era. Finally, the movement of the people with disability understood that it was time to call the Brazilian government to account. They believed that issues involving people with disability had to be in the mainstream of the health and the welfare system to ensure comprehensive health care within the state funding. In 2001, the federal government regulated, only 2001, the federal government regulated rehabilitation assistance, respecting the sensory, financial, physical impairment, and the mental disabilities, and building a hierarchical and decentralized network. At this time, the Brazilian population census already pointed to a high prevalence of physical disabilities like cerebrovascular disease, spinal cord injury, musculoskeletal disease, amputation, cerebral palsy, and other alterations in children. Thus, for this reason, for the census, the state of São Paulo, based in this
Sorry, Professor Linamara, we just have a few more minutes for the session, so if you could wrap up in the next minute.
Create a rehabilitation network, and this example of São Paulo state inspired the federal government. What are the lessons we learned with this movement, this political movement? The legal and the normative framework is necessary but not sufficient. Information is fundamental. Knowing the frequency and distribution of the causes that generate disability, identify where people with disability are and how they live. The most important thing is to give voice to people with disability. They must be empowered and ready to lead. Health professionals have the role of supporting these leaders, providing them with information to achieve better health and well-being, for everyone at all ages. Finally, and the most importantly, is to recognize that the issues of disability is not a problem for the person with disability, but a challenge for every inclusive and fair society. This is my personal experience, yes, how we conduct the public policy for people with disability.
Thank you, Professor Linamarian, for being such a trailblazer. So this session today is drawing to a close, and it's highlighted key areas of health systems that require strengthening and provided some inspiration examples of what is disability inclusive health and what can and should be done more routinely. Making these changes will make health systems that work better for all, whether persons with disabilities, other marginalized groups, minority language speakers, or people with temporary impairments. Looking ahead, we need to make more efforts to make mainstream health services disability inclusive. We need to reach outside the disability community and engage with global health actors if we want to achieve this. There are at least 4 reasons why this is important. First, to fulfill the right to healthcare for persons with disabilities. Second, to help in the achievement of universal health coverage, SDG 3, and other SDGs, since good health is so fundamental for other areas of participation. Third, to maximize the health and well-being of persons with disabilities and their families. And fourth, to create health systems that work better for all and are more future-proof. We hope that this session has provided inspiration for action, and I thank all of the speakers for sharing their wisdom. We're providing a one-pager which Nick has put into the chat with some of the examples mentioned today and key work that needs to happen. Those in this side event intend to be part of these efforts. UNICEF's forthcoming practice guide will strengthen inclusion in its own health programs, and indeed all the organizations and people represented here are supporting national health systems and are making their marks in different ways. I thank you all for attending and for the co-hosts of this event, in particular UNICEF, who's been the driving force in making this event happen. I look forward to hearing of all of your successes in the near future as your actions have led to disability inclusive health systems. And I thank you very much for attending and wish you a good morning, a good night, a good afternoon, depending on where you are in the world. And I hereby close this session. Thank you.